Good evening. It's an honor and pleasure to be here at the virtual conclave on antimicrobial stewardship in healthcare institutions in the continuing quality education series organized by CAHO. And I would like to say thanks to Dr. Sankar Sen Gupta, Dr. Vijay Agarwal, Dr. Lalu, and Dr. Anuradha for this opportunity. And also congratulate CAHO because CAHO is a very dynamic and proactive organization. And what better time to talk about antimicrobial stewardship than this, because in the last 1 year and couple of months, we have seen rampant misuse of antibiotics. And because of the fact that we didn't know what was happening, everybody was providing an antibiotic cover and antimicrobial stewardship went for a toss. So it's the right time to start discussing about this. We've had some wonderful lectures. Dr. Victor Rosenthal, who's talked about the global scenario. He's a colleague and a good friend. And then we had Dr. Bala talking about the basis for an antibiogram and the selection of the antibiogram for successful implementation. And now we come to my topic, which is the preparation of an effective antibiotic policy, challenges and solutions. So I'd like to start with something a little dramatic, and that is, imagine a world without transplants, cancer treatment, joint replacement, intensive care, or bacterial infections. Imagine a world without antibiotics. Now it's difficult to imagine, and you must be wondering why I'm saying this, but this is where we are headed to. Antimicrobial resistance in the world as well as in India is at an all-time high. So in every continent of the globe, we have carbapenem-resistant Enterobacteriaceae, we have extended-spectrum beta-lactamases, we have methicillin-resistant Staph aureus, we have multi-drug-resistant Pseudomonas, and we have carbapenem-resistant Acinetobacters. Even in India, we have similar situation. MRSA is to the tune of about 43%, ESBL and E. coli and Klebsiellas are about greater than 70%. We have carbapenem-resistant Enterobacteriaceae E. coli about 12 to 16% and Klebsiella 57%. Now they could be up and down. This is just an approximate estimation from the whole of India. We have vancomycin-resistant Enterococci, we have carbapenem-resistant Acinetobacter, and we have MDR Pseudomonas to the tune of 42 to 47%. Colistin resistance is also creeping up, and now it is to the tune of 4 to 10%. We have all the people who are influential and at high positions talking about this. So Dr. Tedros, who's the Director General of WHO, has said never has the threat of antimicrobial resistance been more immediate and the need for solutions been more urgent. Our Prime Minister also is often referred to it, and in the Mann Ki Baat he said self-medication in the use of antibiotics can lead to antibiotic resistance. We have the previous Director General of WHO, Dr. Margaret Chan, who said a post-antibiotic era means in effect an end to modern medicine as we know it. Things as common as streptococcal throat infection or a child's scratched knee could once again kill. And then we have ex-President of United States, President Barack Obama, saying the evolution of antibiotic resistance is now occurring at an alarming rate and is outpacing the development of new countermeasures capable of thwarting infections in humans. So the problem is really grave. Deputy Director General of Programs at the WHO is Dr. Soumya Swaminathan, who has also talked about the irrational use of antibiotics in veterinary and agricultural use. And this was published in the ICMR published treatment guidelines on antimicrobial use in 2018. Now let's look at some papers of COVID-19 and AMR. So every paper that we have, there were many papers which came out, and all of them have talked about the fact that the antibiotics were not needed so much as the antibiotics have been given. For example, 70% of patients received antibiotics despite less than 10% having bacterial or fungal co-infections. WHO has also done a study, and they talk about the fact that 79 to 96% of COVID-negative patients were taking antibiotics inappropriately, believing that they would prevent infection, whereas only 15% may actually need them. And that has caused a dip in our efforts against antimicrobial resistance. So my topic will be preparation of an effective antibiotic policy, challenges and solutions. We'll start with the basics. What is an antibiotic policy? Why do we need an antibiotic policy? What is an effective antibiotic policy? How do we make the antibiotic policy? Challenges and solutions. An antibiotic policy is actually a mother document. It is a set of principles to guide the implementation of prudent and rational antimicrobial prescribing in the hospital. This is the larger document, the umbrella document. So, antibiotic guidelines come under the antibiotic policy, and they are specific recommendations for antibiotic treatment or prophylaxis for particular infections, diseases, or syndromes. Why do we need an antibiotic policy? Now, we do realize that AMR is a global public health problem. It is the 21st century plague, and we can still die of a multi-drug resistant infection and also cause increased morbidity, no matter how technologically advanced we become. Newer antibiotics not being able to keep pace with the march of resistance. Healthcare organizations are the hotbed of resistance. We have a deadly cocktail of compromised, sick and aging population, a variety of infectious agents, invasive medicine, the era of heavy antibiotic usage causing antibiotic selection pressure, and so we need an antibiotic policy to minimize the morbidity and mortality, and also to preserve the effectiveness of the antimicrobial agents in the future. So, in that particular patient, it reduces the morbidity and mortality, and we also need to preserve the effectiveness of the antimicrobial agents for the entire community. So, we should avoid getting into the post-antibiotic era. And this is what is a selection pressure. So, once we expose the particular patient to antibiotics, it kills the sensitive strains, but the resistant strains start multiplying. So, a predominantly sensitive population is replaced by a resistant population. What is the solution? Either we can optimize the antibiotics that we have, optimize the usage of the antibiotics, making the best or most effective use so that we prevent the emergence of the antibiotic resistance, or we can prevent the transmission, and that is done by the good infection control measures so that antibiotic resistance is not transferred from one person to another. How can we optimize? We can practice diagnostic stewardship, and we have some lectures maybe later on on diagnostic stewardship. That means giving the right test to the right patient at the right time. That means we must collect the sample for culture appropriately so that we get the correct bug, we identify the correct bacteria, and then we get the correct antibiotic sensitivity pattern. Then we must practice antimicrobial stewardship, and that is practiced by a good antibiotic policy. That means which antibiotic to give to the patient, what is the pharmacokinetics, what is the pharmacodynamics, when to give it, in what dosage, etc. And then is the use of vaccines. So we are going to be talking about the antibiotic policy. This is a multiple task activity with multiple partners, multidisciplinary team approaches, multimodal strategies, including social behavioral sciences. So in a healthcare organization, the first step, just like Dr. Bala had said, is an antibiogram. That leads to the formation of an antibiotic policy, which is, like I said, the mother document. Then we have the antibiotic guidelines, and once we have the antibiotic guidelines, we can implement them, we can audit that, and this all comes under antibiotic stewardship. So now let us look at some of these things. So what is an effective antibiotic policy? It should be simple, it should be clear, it should be clinically relevant, it should be flexible, applicable to day-to-day practice, available in a user-friendly format such as a pocket guide, web-based, or an app. We don't want a whole thick antibiotic policy to lie on the shelf somewhere, and when we want to give the antibiotic to a patient, we go searching for that booklet. It should be something which we can use very, very easily, for example, on our smartphones or in a pocket guide. And it should be developed by those who use it. That means there should be ownership of this. So like I said earlier, the antibiotic policy and the antibiotic guidelines are sometimes used synonymously. The antibiotic policy will be the overall mother document, and the antibiotic guidelines will be the specific ones. Now, what is the scope of the antibiotic policies? Now, let's look at the scope of the antibiotic policies. We talk about the guidelines, which is the prophylaxis for the surgical treatment. We have the empirical guidelines before the culture treatment, and we have the targeted therapy as also the reserve antibiotic. We have special recommendations for high-risk immunocompromised patient, and then we have certain recommendations for healthcare-associated infections and community-associated infections. And running the common thread which runs through all three is the good practices for antimicrobial prescription. So the entire scope of antibiotic policy points out to the optimal selection, dosage, route, and duration, alternatives for allergy to first-line agents and for adjusted dosage in patients with impaired liver or renal functions, de-escalation choices, advice on results of therapeutic drug monitoring, and also focusing on diagnostic stewardship. It should not be like this. For example, we should have the top management support and commitment from perspective of human resource as well as monetary. We should not have a CEO who's warning the microbiologist that AMS is one thing, but I'm responsible for the revenue of the hospital. Don't keep messing with the treatment and the surgeon who brings in the maximum revenue. So the top management has to provide support in terms of people who are going to work in the antimicrobial stewardship and formulate the policy, as also probably incentivize them in some way, though it's not taken off in India as of now, but it's just a thought because it involves a lot of work. What are the prerequisites for preparation? It should be based on the local antibiograms. It should also take into account the national and the international guidelines. It should include the pharmacokinetics, pharmacodynamics of these medicines, adverse effects, potential to select resistance, and cost. It should be syndrome or disease based. The patient is not going to come and tell us, excuse me, that I have UTI. So we have to look at a syndrome. For example, is it the blood that is being tested? Is it the respiratory secretions that are being tested? Is it the urine that is being tested? Or is it some other, the basic syndrome which we are going to diagnose? It should specify the type of clinical setting, that is it outpatient, is it inpatient, or is it an ICU setting? And it should provide evidence-based strength of recommendations and a rationale. The levels for prescribing antibiotics should be set as first line in all cases if everything is sensitive, and second line to be released only in case of multi-drug resistant infections. Reserve antibiotics use should follow pre-authorization. Now we have to detail it. So how do we go about it? We set a multidisciplinary antibiotic management committee. This is a committee with 6 to 10 members with expertise and experience in different subjects. So there should be infectious diseases if they exist, internal medicine, surgery, pediatrics, nursing, infection control, quality department, microbiology, pharmacology, hospital pharmacy, IT department, which has a huge part to play, statistician, even the human resource because they're going to provide you with the resources, and of course the top management. And at least one member should have the skills to conduct literature and systematic review. Who is the leader? It could be anybody. It could be an ID physician, it could be a microbiologist, it could be a pharmacologist, a critical care specialist, or any clinician. It should be somebody who has the expertise to understand and has a little bit of time and passion to deal with this particular thing. The draft is finalized, it is circulated within the department, they should have a complete buy-in and have meetings with the department. So when we started off by making the antibiotic policy in the hospital, we started with each and every department. So we looked at, for example, the pre-surgical, we sort of took out the guidelines and we wrote a framework. And then we invited everybody from the department to come and sit in, and then we tried to tell them that this is your policy, so you have to tell us what you want to use, and then there should be consensus within the entire department. So this is one of our snaps where we are discussing about the antibiotic policy. So this is the process which I have put into a run chart. Healthcare associated infection data and the surveillance of antimicrobial resistance and antibiotic consumption should come into together a cumulative antibiogram. Then a multidisciplinary group should draft an antibiotic policy. Then we should have auditing of the effectiveness of the outcome. Then we should have a final antibiotic policy which will ultimately lead to antimicrobial stewardship. And all the stakeholders should be together in this. We should also review the national and the local antibiograms, and we should look at an accessible policy in terms of a mobile app. We should conduct trainings and we should do audits. What are the good practices while prescribing antibiotics? These are the 10 golden rules for antibiotic prescription. Consider whether or not the patient actually requires an antibiotic. Avoid treating colonized patients who are not actually infected. Give the antibiotic for the minimum length of time that is effective. Consult with the team regarding PK/PD. Review the duration of antibiotic therapy after 5 days. Do not give surgical prophylaxis beyond 24 hours. Avoid overuse of combination therapy except for indications. Initial empiric antibiotic therapy should be based on the policy. hit hard and hit fast, and then de-escalate. And if there's no clinical response within 48 hours, reassess the patient. And some antibiotics have to be restricted and a special form has to be filled for them. This is the surgical antimicrobial prophylaxis for pre-operative patients. Now, this was formulated with cooperation and inputs of surgeons from different specialties. So, we call the general surgeons, the neurosurgeons, the gastrosurgeons, and all kinds of gynae people. Everybody had been separately called, and we looked at the guidelines and then formulated this policy. The elements of surgical antibiotic prophylaxis is, of course, the selection of prophylactic antibiotic, the timing, the route, the dose, if redosing is required, and the duration. The general instructions for surgical antibiotic prophylaxis: the prophylactic agent chosen should have activity against the most common surgical wound pathogens. Patients receiving therapeutic antimicrobials for a remote infection should also be administered an extra dose. Sometimes, people ask us, this person is already on antibiotics, now he is undergoing a surgery, should we give the surgical prophylaxis? Yes, you should administer an extra dose within 1 hour of the surgery starting, or wherever the surgeon feels that he is going to give an incision. Administration of the first dose of antimicrobial should be done within 60 minutes. Vancomycin and fluoroquinolones should be administered 120 minutes before surgery because they require prolonged infusion times. Intravenous administration is ideal because it produces reliable and predictable serum and tissue concentration. Dosing is based on the patient's actual body weight. If the patient's actual body weight is more than 20% above the ideal body weight, the dosing weight can be determined by this formula. So, it's not really multiplication, but it is by this formula. So, it will be a little more. We have to administer a second dose only if the surgery lasts longer than 4 hours, except vancomycin, fluoroquinolones, and aminoglycosides. And duration of antimicrobial prophylaxis should be less than 24 hours. For surgical procedures, for cardiac and ortho surgeries, it is 48 hours. So, this is the most important thing, that it should be less than 24 hours and we must audit this. So, the four most important thing is we should give the appropriate antibiotic, we should give it within 1 hour, we should redose it if required, and we should stop at 24 hours. This is how the policy looks. So, just to give you an example, we say type of procedure, we say drug of choice, and then we have alternative agents in patients with beta-lactam allergy. For example, let's take a hip fracture repair. So, it's cefuroxime plus minus amikacin, and the alternatives are clindamycin and vancomycin, and then it talks about the recommended dose, the half-life, or the recommended dosing interval. So, this is for everything, for cardiac, for thoracic, for CTVS, for oncosurgery, ENT, obs and gynae, ophthalmic, etc. Now, let's come to the empiric and targeted therapy guidelines. Empiric means the administration of antibiotics directed against the most likely microbial agent before the results of culture, and targeted means the usage of antimicrobial agent against infection by specific microorganisms after culture. De-escalation to a narrow spectrum antibiotic to avoid collateral damage. It's just like, if you want to swat a fly, we will obviously use a fly swatter and we will not take a gun out. So, we need a narrow spectrum antibiotic to tackle the diseases targeted. It should be a targeted treatment. Escalation in case required. The empiric guidelines are based on 4 common infections. Just like I said earlier, it's a syndromic evaluation, like a bloodstream, a urinary tract, respiratory, and pus. The patient stratification should be in type 1, 2, 3, and 4. The 5 most common bugs and their sensitivity pattern is seen, and the location should also be mentioned. So, this is the patient risk stratification. Now, the patients are divided into type 1, type 2, type 3, and type 4. Let us look at the characteristics of each. Type 1 patient has had no contact with the healthcare system in the last 90 days and had no prior antibiotic treatment in the last 90 days, and the patients are young with no comorbid condition. The type 2 patient has a history of contact with the healthcare system in the last 90 days with or without minimal invasive procedures. The antibiotic used in the last 90 days or old, greater than 60 years with comorbid conditions like diabetes, asthma, chronic bronchitis, cardiovascular disease, etc. The type 3 has a hospital stay greater than 5 days and or major invasive procedures or recent long multiple antibiotic use or comorbid conditions leading to immunocompromised state like AIDS, neutropenia, use of immunosuppressant, structural lung diseases, etc. And a type 4 is a type 3 patient with or without fever. It could be sepsis or septic shock, and basically this patient is really moribund and very, very sick. This is the empiric or the directed therapy. Now here I'm just giving you an example. It's just one example of our empiric or directed therapy. It's a bloodstream infection. And if we have taken the 5 most common bugs causing the bloodstream infection, for example, Klebsiella pneumoniae, E. coli, Enterococcus, Acinetobacter, and Staphylococcus aureus. And after that, we apply the patient risk stratification. We look at the prevalence of these particular bugs. So you see Klebsiella pneumoniae is the top one. And then we see which antibiotics is it really sensitive to. So that is how we look at the empiric policy. And then this is the patient risk stratification, and then it tells us everything down to step down, that how do you de-escalate, if required to escalate, how do you do that, before culture what do you do, and after culture what do you do. This is the empiric or the directed therapy antibiotic data monitoring form which we have, which I'm sure Dr. Namita will talk about, because only when you audit can you actually have a correct implementation. And then lastly we come to the reserve antibiotic policy before we go on to the challenges. WHO has talked about a variety of antibiotics which we should keep under reserve, access of the antibiotics, watch the antibiotics or reserve them. And accordingly, we have made a reserve antibiotic form over here where we have 16 drugs which are included, and everybody is expected to fill this form before they authorize a reserve antibiotic. Last of all, I would like to say that the periodic review is very, very important of the antibiotic policy. It could be a yearly review, annual review, because it has been shown by studies that sometimes when you withdraw antibiotics, they retain sensitivity. Sometimes when you add on antibiotics, they lose the sensitivity. Now let's come on to the challenges and solutions. Very simple. I've put it into boxes and we'll go over it very quickly. The first challenge is the antibiogram. Is an antibiogram always available, and how accurate is it? So now your labs must have an EQUAS. If we don't have a lab or a hospital where the antibiogram cannot be available, look for the immediate neighboring hospital which uses the antibiogram and have some sort of partnership towards that. And gradually we can move towards regional antibiotic policies. The second challenge is the AMS committee. Do we have a good representation? Who is the leader? Do people have the time to devote to it? Do we have a statistician, and do we do a literature survey, and what is the compensation? And we can have a solution by having people, more than one person in each specialty, by people assuming dual roles, and by taking top management into the fold. The third challenge is the formulation of the policy. Now, do we have national AMR data? Because we want to look at it. And nowadays, a lot of collaboration is taking place. We have the WINSAR, we have the ICMR surveillance and whatnot. This is the WINSAR, which is a partnership of the WHO IAM network, and this is doing wonderful work in collating the surveillance data. The fourth challenge is the alignment with the national policy. Should you align with the national policy? Yes, you should. But where you have to make local changes, because prescription patterns vary widely, one should do so. The next challenge is, are we on the same page? Now, sometimes in departments, you have one particular person prescribing one for surgical prophylaxis and the other. So likewise, we will have a lot of non-compliances. So all the departments have to come together on the same page. The last is the accessibility and the ease of use. Now, if we have to make it easily available, we have to integrate it into technology. And I'm going to just show you some snapshots of how we have integrated it into technology. This is our surgical antimicrobial prophylaxis integrated with the app which we had, which is called the Artemis Connect MD app. Now here we have a patient. You select a patient. You go on to the files of the patient. You go on to the surgical prophylaxis. Then you go on to what procedure is being performed. If it is a hip fracture repair, you will get the drug of choice for the adult and you'll get the drug of choice for the pediatric. And it is incorporated into an app which is available on the phones of the clinicians. This is again for the Empiric. We already have a digital AMS app which many hospitals have now. And it is again based on the patient type, the ward type or the infection type. And then you have the 5 most common organisms. Again, it is the same as I told you. We have the therapeutic antibiotic, and then we go on to the patient type. And if it is the ICU, we have a different ecology. If it is the ward, we have a different ecology. And the answer will come on the app of the person who is using it, that is the user. This is the reserve antibiotic. Again, it is integrated into our hospital information system, and nobody can move towards taking that reserve antibiotic if you do not give a reason for it. So this is all incorporated, and it is very, very simple to use. And the last challenge is getting out of our own well. So we have to increase awareness, which Kaho is doing wonderfully by promotions, publications, teaching, and training. So we train all our people all the time, and we have even training for the patients by antibiotic posters, by small sections for the public information literature, etc. And we release antibiotic booklets in the hospital for the judicious use, and we create a lot of awareness in the hospital to be able to do that. So this is all what I had to say on this, and thank you very much for a patient listening.
Thank you, Dr. Namita.
We know that in a country like India, there's an indiscriminate usage of antibiotics in animal husbandry.
Yes.
Most of it is coming to human population through food chain.
Yes, sir.
And either the antibiotics or their metabolites are coming into human. Some of them, mostly non-vegetarians, they develop post-surgical site infection which are not responding so many antibiotics. What is your view about this?
Yes, sir. Like I said, it's a wonderful question. Wonderful question. What I really said at the beginning, that the hospitals is only a part of the problem. So, the other side of it, use of antibiotics in other sectors, in animal husbandry, in agriculture, present in the environment, that is all affecting. And I'm sure Kaho will hold another conference on, the environmental aspects of it. So, yes, you are very right. They do come into our ecosystem, and these days there is a lot of talk on the microbiome, because what we are ingesting into our body and what is coming inside, and there's lots happening in our gut. And the gut is the epicenter now of antimicrobial resistance. So it is a very, very relevant area. And I think if we want to achieve the antimicrobial stewardship in the entirety, we must look at all the aspects. So hospital we are already doing, but more into the animals, the agriculture, and it is
absolutely
one health now. So it is not really segregated into portions. So we have to follow the One Health pattern, and I'm sure we should have wonderful conferences, on One Health, where we get everybody together and sort of prevent antimicrobial resistance. Thank you.
I am one of the advisors to some of the neighboring countries, including UAE.
Yes, sir.
UAE has banned import of any meat and poultry and products to that country, India.
Yes,
and we are also losing the business. And there should be policy which need to be developed.
Absolutely.
People like you to
fight. And I'll just tell you a personal thing here. I used to be a non-vegetarian earlier for many, many years. And now in India, we have certain small portions of antibiotic-free chicken and mutton and the other kinds. And of late, for the past 2 years, I have turned into a vegetarian. I'm a very happy vegetarian now, so as to say. But I think if we have to enjoy non-vegetarian food,
you are a vegetarian. I have become a vegan.
Okay,
I have become a no milk product.
No, yeah, I understand, because milk is also a portion of that. So I think going into future, we must have antibiotic-free milk and antibiotic-free non-vegetarian food. It's a very important
antibiotic-free may not be possible. I am for saying antibiotic-safe food, antibiotic-safe country.
Yes, and segregate
antibiotics.
And segregate those antibiotics which will be only used in these conditions, and some reserved for the human use. So these are some of the future directions. Yes.
That's what I said. Indiscriminate usage of antibiotics should be stopped.
Yes, absolutely.
Thank you for wonderful talk.
Thank you, sir.
What's the recommended pre-op antibiotic policy for patients already on ongoing antibiotics when taken up for surgery?
Yes. I actually had written it in my slide, but somehow, because I was taking up a lot of material, so the answer to that is that if a person is already on treatment for a particular infection, we must give an additional dose 60 minutes before the surgery, because that is for a treatment. Whatever the person is taking is for a treatment, but according to whatever surgery is being performed during that time, this is mostly for the skin flora, etc. The cefazoline or the cefuroxime is the one which is recommended for most, except that, of course, according to your local antibiogram, you have to add certain other antibiotics according to your policy, but an additional dose must be given in the morning, just before 60 minutes before the surgery. Yes.
Thank you for your excellent elaboration, Dr. Namita. Thank you.
You.